Now you might say, well, this is all good, but this is for patients on the cohort level. But what about for individual patients? Because you're talking to a patient, not to a group of patients. We and others have shown that when you use pre-treatment information, in particular cytogenetic molecular data, there really is somewhat limited ability to predict relapse or survival for individual patients. So we're interested to see how much we learn more by integrating results from MRD testing into these prediction models. And we used a patient cohort from the SWOG SO106 study. And just like in many other AML studies, when you used MRD results after induction chemotherapy, it nicely stratified our patients in remission based on, with regard to outcome based on MRD test result. But when we looked at the models that would predict outcome, and we used the AUC method approach for this, we could confirm what we saw before in other cohorts, namely that when you use pre-treatment information such as age, performance status, some basic genetic information, molecular profile, that our ability to predict outcome is really limited. And results from MRD testing add some value to this, but as you might see, the difference is maybe less than you would have hoped for. So there's a benefit, but maybe not as marked as you wished. But these results were all done in patients that were in morphological remission. But what about ignoring the morphology call from the pathologist and just looking at MRD test results? And as was nicely shown by a large study in pediatric AML, there's quite a discordance between what the pathologist calls as remission based on 5% blasts or more than 5% blasts and what you might conclude from a flow cytometry-based assessment for MRD. So when Dr. Inaba and his colleagues looked at individual subsets of patients on this study, what they found is that among patients that had a negative MRD test, the outcomes were really identical between those that the pathologist called to be in remission, in morphological remission, those that were called to be not in remission. And even among patients with a positive MRD test, there was really very little difference. So in other words, if you had information on MRD testing, you would learn very little from looking at morphologic information. On the other hand, if you started out with the pathologist telling you you have either less or more than 5% blasts in the bone marrow, test results from MRD assays really nicely separate patients prognostically. And you might see how similar these outcomes look, even though that's perhaps not a very fair comparison. So given the repeated demonstration that patients with a positive MRD test at the time of transplant have a very high risk of relapse, we asked the question, well, how different are outcomes for those patients with patients that went to transplant with florid disease as defined by having more than 5% blasts in the bone marrow by morphology. And within the limitations of a retrospective analysis, what Dr. Rocky found, who is now at the NIH, is that the outcomes really looked remarkably similar between patients transplanted in florid disease or those in morphological remission, but with a positive MRD test, in this case done by flow cytometry. So said in another word, if you used an MRD test-based approach to define your remission status, you would be much better in prognosticating outcomes after transplant. Now you might say, well, this is a single-center study and this is perhaps not reproducible. So it was very reassuring to see that Chris Horrigan, who's at the NIH, has found a very similar observation in a cohort of patients transplanted at the NIH, where MRD was detected by molecular assays. Again, if you're using an MRD-based definition of remission, you're much better in prognosticating patient outcomes after transplant. So data such as those showed in the last few slides certainly make a good argument to integrate results from MRD testing into standard response criteria, just like the ELN has done in the 2017 guidelines. But blood counts, or simple things like blood counts, still do matter, and that was nicely shown by a recent study published by Dr. Chen and Dr. Esty from our institution, examining a little over 100 patients that received AML chemotherapy but then did not undergo transplantation. And what you can see on this slide is that really only patients who had full blood count recovery and the negative MRD test at the time of remission had reasonably low risks of relapse, whereas patients with full blood count recovery or a positive MRD test, or all the patients with incomplete blood count recovery, regardless of MRD testing, had quite high relapse risks. So to summarize, why would I recommend routine MRD testing? There's really two reasons. One is it does allow us to refine prognostication and risk stratification, both at the cohort, at the individual patient level. And while I'm the first to say that I don't really know what to do therapeutically with this, I do think that this information is valuable for the informed decision-making process, and it certainly allows us to identify patients in whom one should test in a controlled fashion what to do with this information. And I do think it's time that even though morphological disease assessment is an old or gold standard, it's time to move towards an MRD-based definition. And in a sense, this recommendation follows this saying, don't let the perfect be the enemy of the good, something that I hear very, very often from one of my mentors, Dr. Esty, and it certainly applies to this situation. It's very clear that MRD testing is not perfect at this time, and it may never be. There's many open questions related to timing, interval of testing, but even the methodologies themselves. But the sheer fact that the data are so consistent across the studies, despite all these inadequacies and differences, to me just speaks to the value of using it. But certainly what I want to emphasize is that at this point, even though I do recommend routine testing, at this point it should be done in a centralized, experienced laboratory until efforts to develop standardization or harmonization better across the places. So when I tried my arguments a few days ago, I was not particularly successful, so I hope I did a better job here. But regardless of on which side of the aisle you are, I think we're all in this together, and there's no doubt that MRD is coming. Thank you.